Yes.
Yes. Okay, great. So thank you for that introduction. What I thought I'd do this morning is expand this talk a little beyond insular tumors and talk about sulcus-guided resection of diffuse gliomas. What I thought I'd do is introduce this concept of sulcus-guided resection for maximizing resection and minimizing neurological deficits in patients with non-enhancing gliomas. I'll talk about the role of surgery in general in resecting diffuse gliomas, and then talk a little bit about our technique of the sulcus-guided resection, and including the insular region, and give you some outcome metrics. So I think for the surgeon, it's critical to recognize that there's a major difference between contrast-enhancing tumors and non-enhancing tumors. Compared with contrast-enhancing tumors, where the tumor cells are abutting each other, and inside a contrast-enhancing tumor, there are only tumor cells, a non-enhancing tumor, which is the majority or all of the lower grade gliomas, and these are hypo-intense on T1 weighted images or hyper-intense on FLAIR or T2 weighted images. In these non-enhancing tumors, the tumor cells are juxtaposed and infiltrated with normal neurons. So in a non-enhancing tumor, you have neurons next to tumor cells. So what that means is that when we take out a non-enhancing tumor, there is the major risk of removing normal functional brain. And so there is a major dichotomy or conflict in resecting non-enhancing tumors, particularly these lower grade gliomas, between obtaining a complete resection and not causing any neurological dysfunction. So we really, for these non-enhancing tumors, have to balance the oncologic goal of complete resection with the functional goal of maintaining neurological outcome. So let's look a little bit at the oncologic goal. Whether the tumor is in the right frontal lobe, the insular, or even here in Broca's area, when a neurosurgeon sees a patient with a non-enhancing tumor, they have to ask the question about the time and the type of intervention. Will they do the surgery or do an intervention now, or will they take a watch and wait approach? And will they do a biopsy, or will they do a radical resection? So with regard to the timing of intervention, I think the data is becoming increasingly clear that there is good reason to perform early interventions and not take a watch and wait approach. Probably the most important reason is that when you look at the MRI scan, you cannot determine from that MRI scan the grade of the tumor or the histological, and now, and most importantly, the genetic alterations. Obviously, the grade and actual histological definition of the tumor determines the prognosis and increasingly the most effective treatments. So as you heard from Dr. Hughes, most of these non-enhancing tumors are IDH mutant tumors, but there's two different types. You can either have the 1p19q IDH mutant tumors, which is an oligodendroglioma, or the ATRX deleted tumor, which is an astrocytoma. And these have very different prognosis, and it's very important to know right up front which of these tumors you're dealing with. In addition, many of these non-enhancing tumors are actually, or a subset of them, are actually IDH wild type. And these are very distinct from the IDH mutant. And in fact, if they have these chromosomal abnormalities, these what could be considered a low-grade tumor because it's non-enhancing can actually be classified as a glioblastoma based on these molecular analyses. In addition, the IDH mutant tumor, particularly the astrocytomas, as Dr. Hughes pointed out, can be upgraded to a higher grade tumor based on the molecular finding of a CDKN2A mutation. So in addition to actually affecting prognosis, the treatments of these tumors now vary and are now known based on evidence, clinical trial evidence, which we'll hear later about. And so it's really important to upfront to identify the type of tumor and therefore to be able to discuss this with the patient, both in terms of prognosis and treatment options. The second question is, should you perform a stereotactic biopsy or a maximal resection? And I think there are multiple reasons now to advance the idea of maximal resection. The first is that you can improve symptoms. Obviously, if the tumor is large, you can decrease intracranial pressure, but you can also reduce the rate of seizures by resecting these low-grade tumors. By performing a maximal resection and providing a large amount of tissue, you can improve diagnosis, as we've shown in several papers where the larger the amount of tissue, the more accurate diagnosis. But most importantly, we really want to improve survival. And it's now been pretty much well demarcated that the greater the extent of resection, the longer the patient's survival. So here's just, I will highlight two papers outlining that result. The first is this very important paper from the Radiation Therapy Oncology Group. 9802 was the clinical trial. In this trial, patients with non-enhancing tumors who were less than 40 years old and who underwent a gross total resection based on the surgeon's report were simply followed. And when they went back and looked at the MRIs, they saw that even though the surgeon thought there was a gross total section, there was left behind non-enhancing tumor. They could actually categorize and measure that as less than 1 centimeter, 1 to 2, or greater than 2 centimeters. And you can see here that with each increase in residual tumor, there was a greater chance for recurrence. And you could dichotomize that based on less than 1 centimeter or greater than 1 centimeter residual and see a significant improvement in survival with the less amount of residual, indicating that the greater the extent of resection in this prospective but observation study showed the better resection. Probably the most important data on this topic is this paper from Jacola, published in JAMA back in 2012. This, I'm sure many of you are familiar with. This is essentially the closest we'll ever get to a randomized trial of this topic. The paper comes out of Norway, where all patients who lived in a particular area of Norway had to go to hospital A based on the nature of their medical system. And patients who lived in another part of the country, all of those patients had to go to hospital B. And it turned out by chance that the patients who went to hospital B, the philosophy there was to perform a biopsy and a watch and wait approach, whereas the patients who went to hospital B, all of those patients underwent a radical resection. And when they looked at the outcome of these essentially randomized patients, because they were forced to go to the hospital in their area, it turned out that the patients who underwent the biopsy had a median survival of 5.9 years, whereas the patients who underwent the radical resection actually had not reached the median at over 10 years of follow-up and observation. So this is very strong, near class 1 evidence that the greater the extent of resection, the more radical resection, the longer the person will live. So based on this, we really have to push now to try to resect as much tumor as possible. And that means we have to balance this goal of complete resection with neurological function. And that means we have two challenges. The first challenge is what I call localization or spatial assessment. We have to precisely define the borders of the tumor intraoperatively, and we also have to identify the veins and arteries supplying that tumor and preserve those while we take out the tumor. And the second thing we have to do is do a functional map, because as I said, these tumors are non-enhancing. You can have infiltrating normal cells amongst the normal brain, or infiltrating tumor cells amongst the normal brain, and therefore we have to identify eloquent brain and the fiber tracts. Now we have a large number of surgical adjuncts to meet this goal. For spatial mapping or spatial assessment, we can use computer-assisted image-guided surgery, intraoperative ultrasound. We also have intraoperative MRI if many institutions have that capability. Most importantly, we can perform functional mapping to identify normal eloquent brain. We can do this preoperatively with functional MRI, which you just heard about from Dr. Kumar. We can also use transmagnetic stimulation. And then intraoperatively, we have a whole array of functional mapping techniques, including phase reversal and brain stimulation with awake craniotomy. I'm not going to focus so much on these. Dr. Sujit Prabhu will be following me, and he will be focusing specifically on our ability to functionally map the brain and do brain stimulation with awake craniotomy. But clearly, this awake craniotomy is the gold standard for motor mapping, and with those adjuncts, we can really improve outcome. But I'd like to propose that there's another adjunct that's important for us in resecting these tumors, and that is the idea of this en bloc resection using the sulci to guide the resection, essentially based on the tumor anatomy. And what I'd like to propose is that the best way to resect these tumors is to perform an anatomic circumferential dissection using the sulci to define the tumor. So many people are taught to go directly into the tumor and do what we might call a piecemeal intratumoral debulking and then move to the edges. But what we have found is that by doing a sulcus-guided resection, dissecting down the sulci, we're able to resect these tumors more completely and with a much more bloodless field. So the concept here is that most non-enhancing tumors do not violate the pial surfaces. Therefore, the borders of the tumor are actually defined by the surrounding sulci. And indeed, if you look carefully on most MRIs, the base of the sulci is often near the deep side of the tumor. So what that means is you can perform an anatomic en-bloc dissection using these sulci as boundaries. And the advantage of this is that the boundaries of the tumor are identified early, and that results in less brain shift as you're removing the tumor. So the navigation systems we have remain faithful. The base of the sulci actually often define the depth of the tumor, and you can use that as a landmark. It also results in not injuring the passing vessels, because these vessels are identified in the sulci, identified early, and then the small perforators that come off the vessel and go into the tumor can be devascularized, can be cut, devascularizing the tumor and resulting in a bloodless field. So as I said, instead of going into the tumor, the proposal, or what we like to do, is actually dissect and open the sulcus on all sides of the tumor, or do a subpial dissection, dissecting down to the base, and then the passing vessels we coagulate and cut. So the surgery involves two parts: a spatial mapping, in which we first use our intraoperative guidance to define the sulci that surround the tumor. Here's an example of the frontal, the middle frontal, the precentral sulcus, and the superior frontal sulci defining the tumor. And then the edge of the tumor was defined here using the computer guidance. The second stage of the surgery is to perform functional mapping. Here, this was the motor cortex, and stimulating of this area resulted in movement of the face and the hand. And I'd like to point out that if you use the sulci, many tumors that seem like they can't be removed because the tumor might be in a functional brain are actually just simply part of an expanded sulci. So here's an example where you would stimulate here, and that causes movement of the hand, and you might think that, oh, that's overlying the tumor. But in fact, it's not. The tumor is simply bulging and pushing this sulcus. So if you do a sulcal dissection, you can actually resect this tumor, not violate the sulcus, and preserve the gyrus with the function in it. So the sulcus-guided resection improves your ability to maximize resection without causing injury to functional areas. Once you've done the spatial mapping and functional mapping, you then open the sulci, you dissect the vessels, dissect down to the base of the sulci, and as I said, identify the passing vessels in the sulcus, coagulating and cut any perforators. And then get underneath the tumor, identify the border, and then remove it en bloc. Here's an example of a case in the tumor in the right frontal region, just in front of motor cortex. Here you see the hand knob. We take that patient to the operating room, do functional mapping. This turns out to be the hand and the face. And then we map the tumor with the surrounding gyri, and then proceed with the surgery. And here's just a little video of the surgical resection. You can see that we're not starting the operation by going into the tumor. We start by opening the arachnoid over the tumor and then dissecting down the sulci. Here you see us dissecting in the inferior, in the middle frontal sulcus. There's a vessel in that sulcus. That vessel is supplying distal brain, so we preserve that, coagulate any small perforators coming off that vessel, and then continue to dissect that vessel free so that all of the surface, these vessels are maintained intact, and we don't injure any of these vessels. On the posterior end of this tumor, again, this was the motor cortex. Here you see the veins overlying the precentral sulcus. Using sharp dissection, we open the arachnoid, dissect those veins, and there's an artery underneath there free. You can see that we now have access to this, this gyrus, this sulcus. Here we're now doing a subpial resection to protect us against the functional area. We dissect down to the base. You see another artery there. Once we're in the base, we now find a plane between the tumor and the white matter. We can use the intraoperative ultrasound or the computer-assisted guidance to help us find that plane. And then we simply dissect circumferentially in that white matter plane, eventually removing the tumor as an en bloc mass. And you can see that this is a completely bloodless surgery with a complete resection of this tumor. And here's the post-op, the intraoperative picture after resection, the nice sulcal border, veins intact. And again, this tumor bulged underneath the motor cortex, but we were able to spare the motor cortex and remove tumor all the way up to the motor cortex, post-op scan showing a complete resection. Here's another example of a left Broca's area region tumor, frontal opercular tumor. You can see on these preoperative T2s and flares that the sulcus is actually near the depth of the tumor, both anteriorly and posteriorly. We take the patient to the operating room. We do our spatial mapping, where you can see here, this is the sylvian fissure, a sulcus in front, a sulcus behind. We do our functional mapping. We can see that these areas are positives for speech, so we don't want to injure them. We then dissect and open these sulci. Importantly, you see here an artery over the surface of the brain that's supplying distally. Here's the post-resection. You see that artery is completely preserved. And then you can see that the walls of this sulcus, the sulci, allowed us to take out a larger tumor without injuring the brain underneath in these areas or these regions that contain speech and language. And here you see the post-op scan showing a complete resection essentially down to the borders of the sulcus. We actually looked at 519 cases in our group, and we were able to show that the sulcus-guided resection was performed in 208 and the piecemeal in 311 cases. And statistical analysis showed that the sulcus-guided resection resulted in a statistically significant improvement in complete resections compared to the piecemeal, and that this actually remained an independent variable in a multivariate analysis, with sulcus-guided resection showing in a multivariate analysis that it was independently associated with improved complete resection of the tumor. So I'd just like to point out that this same approach is the exact approach you can use to resecting insular tumors. So insular tumors are, as you know, located deep to the frontal and temporal operculum. They're surrounded by the middle cerebral arteries, and they are very challenging to resect because of this deep location and this neurovascular anatomy. So what we propose for resecting these tumors, rather than going through the brain, which has become a common strategy, is to do a transsylvian approach, which opening the sylvian fissure and then dissecting into the sulci that surround the insula. The insula is surrounded by a superior periinsular sulcus, an inferior and anterior periinsular sulcus, creating a three-dimensional pyramid. By dissecting down to the bases of these sulci, we can reach the deep portion of the tumor. This also exposes the middle cerebral artery on the surface, which we can coagulate and cut all of the perforators, preserving the middle cerebral artery, devascularizing the tumor, and then actually identifying the lenticular striates based on the depth of the surrounding sulci. And we've used this approach in over 125 patients and had over 75% resection in over 80% of the patients with very good and minimal dysfunction. Here's an example of one of these tumors in the right insula. You can see here on this slice that this sulcus, the posterior periinsular sulcus, or superior periinsular sulcus, is near the depth of the insula. And here's the post-op scan showing a complete resection of that tumor. Similarly, a left-sided tumor, again, you can see how the surrounding sulci reach the depth of that tumor. And then again, a complete resection on the post-op scan. And we use this same approach on many larger tumors that extend from the insula into, for example, the temporal lobe is shown here. We'll often first split the sylvian fissure, dissect into the superior and inferior periinsular sulci, free up the middle cerebral artery, resect that portion of the tumor, and then do the temporal lobectomy. And you can see here a complete resection of that tumor. So in conclusion, surgery is clearly a critical component of the treatment of these diffuse, non-enhancing, lower-grade gliomas. From an oncologic perspective, we want to perform a radical removal, and that's now based on fairly strong class 1 evidence. And from a neurological perspective, we want to preserve neurological function. So to achieve both these goals, we localize the tumor with spatial mapping and perform functional preservation with functional mapping, and you'll hear more about that in the next lecture from Dr. Prabhu. But ultimately, I think the en-bloc sulcus-guided resection method, which uses the surrounding anatomic sulci, help to define the borders of the tumor, devascularize the tumor early, and therefore help preserve functional brain and vessels, leading to a complete removal of these tumors without neurological deficit. So with that, I will close, and thank you for your attention.